have the pleasure of introducing Dr. Gary Wheeler. And as you'll find as he comes up to speak, he has a wealth of knowledge on tobacco. I don't really want to take up a whole lot of his time. I asked him how he wanted me to introduce him. If he wanted me to read his entire bio that's found in the back. Of course, he said no. But I did want to read a couple of things. Dr. Wheeler is certified by the American Board of Pediatrics, American Board of Allergy and Immunology, and the Infectious Disease American Board of Pediatrics. He holds the position of professor and clinical adjunct professor in the Department of Pediatrics Division of Infectious Disease at UAMS College of Medicine. What I do find rather interesting, I'm going to skip down. Dr. Wheeler has been named one of the best doctors in America multiple times over the past 15 years and was recently chosen as best faculty mentor in the Department of Pediatrics at UAMS. So please join me in giving a warm welcome to Dr. Gary Wheeler.
Good morning, and thank all of you for being here today. It's my pleasure to introduce myself to a number of people in this room that I look forward to working with for a long time. All of you are working in some aspect of preventing or treating HIV/AIDS, and I have had a lot of experience with HIV. It goes back a long ways, but it's sort of a different area. It's been about 31 years since we were introduced to HIV and began to learn what it was. We knew that there was this mysterious illness that was crossing our country and the world, and didn't know much about it. And it was a very short time later, it was about 27 years, probably about this month, when I took care of my first baby that had HIV. It took us a little while to figure out what it was back then. A little 3-month-old, beautiful child who presented with PCP pneumonia and died shortly thereafter. And I've watched the fight against HIV go from that time when there was a period of the deepest darkness and hopelessness. And it's the same period that took a dear friend of mine on July 15th of 2001. Happened to be the same day my second daughter was born. But it was at that period in 1991 that we were just beginning to be introduced to the first, possible drug that might work in HIV, which was AZT at the time. Now we call it ZDV. And over a short period of time, really 5 years, for the introduction of protease inhibitor therapy, which literally brought people who had one foot in the grave in short periods of time to the point where they were healthy people walking around again. And it was just an extraordinary period where we developed a lot of hope. At the same time, we were looking at the massive number of infections that were occurring across the world and feeling that there was hopelessness there, where there were limited resources and the cost of medicine was just so vast that no one imagined that we could begin to address that. But since that time, through the help of many people, people like Dr. Nate Smith at the department who I work for, who has been in Africa and have worked to deliver medication and treatments to people that never had access to it before, because of the foundations that have, the Gates Foundation and others that have seen the opportunity to try to address this epidemic on an international basis and have done it well. And yet, here we are in Arkansas, where we have, we're still dealing with HIV, and where we face now new problems that we didn't face 10 years and 15 years ago, where the biggest problems that we deal with are actually getting people to come forward and accept the opportunity of treatment, to come forward and accept the diagnosis and recognize this diagnosis and understand that there's very promising hope for treatment. We're still dealing with insurance companies who look for opportunities not to pay for medicine for an illness that can be treated early and effectively if recognized early. And so we've still got a lot of work ahead of us. And I really am very happy. I moved to the health department from the Children's Hospital about 3 months ago. And I am very excited to be part of a team at the Department of Health and with the many partners that we have in Arkansas, private practitioners, advocates, groups like Future Builders and others that are doing the very, very hard work that we now know is required to help people find treatment, to get diagnosed, and to get to the point that we want to get to zero, which is the new campaign slogan that we all need to embrace. And I want to let you know that I am very excited to be part of the team that's going to help us get there in the near future. I'm very pleased also to talk to you about the other passion that I'm involved with, which is tobacco. It's one of the biggest nightmares of modern life. It's hard to believe that the tobacco industry, which I consider the greatest scourge in America, has profited immensely at the expense of millions. It takes about 5,000 lives a year from this state. And the industry particularly preys upon children. It preys upon the poor. It preys upon those with mental illness to take its money to make its profit. And there's a lot of different ways that it happens, and some come in places that we would not expect. This is the new Snoop Dogg launch of a brand of cigars called Executive Branch. This is part of a YouTube video. The lyrics on the left are from that video. 1 for the money, 2 for the show, 3 to get ready. Now let's blow. Executive Branch, Executive Branch. I urge you to pull up that, go to the YouTube spot, just go Snoop Dogg Executive Branch and look at that. It's one of the most beautifully created videos, incredibly well marketed, and it's going after the target population that we're going to talk about today. Young, poor, African American, people that represent one of the biggest groups of folks that we have. We may be able to pull that up, it sounds like, a little bit later if we get through and have a little time. So you can see how incredibly skilled the industry is at convincing people that they need to smoke by using icons like Snoop Dogg and others to market their products. And the consequences are very severe for all of us. I wanted to talk today about tobacco and HIV, and I have 3 objectives. The first is to review with you what the use of tobacco is among people who have HIV and what the consequences are. Consequences in terms of illness, death, cancer, etc. And then I want to think a little bit about the different risk factors that lead to the development of HIV and the risk factors that lead to tobacco, and see how they overlap and how they're different and how we need to think about addressing tobacco use in people who are living with HIV. And then finally talk about the very limited amount of information that we have out there in terms of research that's involved with helping people quit who have HIV. So I just want to start with some facts. If you look across the country, the rate of smoking is about 20% just in the wide general population. And if we look at the rate of smoking in people who have HIV, there's been various people that have done surveys over the years. You'll see that it's dramatically higher, probably higher than any other groups that we've looked at that we can identify. In 1993, probably the first study that looked at this came out. It was done from Northern California and the San Francisco clinics out there at San Francisco General. And they went to their outpatient clinics and surveyed to look how frequent smoking was. Now, at that time, California had actually a pretty active program. Their rate of smoking was actually less than the national population, probably in the area of around 15%. But among people with HIV at that time, the rate was 54%. So at least 4-fold the amount. So very, very high. And then the studies were continued. There was another one done in the year 2000, which was done up in New England. And it was, again, looking at outpatients who came in for HIV treatment. And about 70% of them were smoking and smoked in the last 30 days. And then, and a lot of those were very heavy smokers. That's another thing that's been looked at, not just are you casual smoker, 3 or 4 cigarettes a day, but these were people who were heavy smokers, typically 2-3 packs a day. And then in 2010, there was another follow-up again out of New York, same sort of thing, about 60%. And again, New York State, New York City in particular, has been leading the fight against tobacco. They probably have lower rates than anyone else. And there again, we're seeing a rate that's about fourfold higher than anywhere else. For those of you who were interested in reading more about it, the reference at the bottom of this slide from the Proceedings of the American Thoracic Society is a really, really nice review of a lot of things that we've learned about patients with HIV, people living with HIV who smoke. And again, I really want to make a big point. You know, for me, this is not so much about people who smoke. This is a personal battle for me with the tobacco industry. People who smoke have basically been tricked at some time in their life into starting smoking. And they are victims. They are not people who have any flaws at all. They are victims of an industry that's very predatory. So our job is really to help people overcome that and not in any way to find any fault with people who smoke. Most people who smoke really want to quit. And that was illustrated in, again, going back to the study from San Francisco. Of the 54% of people that smoked, most of them wanted to quit. 2/3 of them wanted to quit. And particularly the males, it was a largely male population, and even among males, they really had a high desire to quit smoking, but were unable to. Now, I think I've established for you that people with HIV smoke more than we would like, at a much higher rate than the general population. So what are the consequences of smoking? And how does that apply to people who have HIV disease? Well, let's just start with the general population. What are the consequences of smoking for the general population? Most of you probably know that people who smoke have a high risk of lung cancer, but you may not know all the other things that are untoward about smoking that can be bad for you. So one of the first things is the risk of heart disease. And we know and have known since the Framingham studies that were done in New England many years ago that smoking is bad for your heart. You have more heart attacks and heart failure later in life. And if you smoke, it's at a significantly higher rate, probably 2 to 3-fold more than it would be if you didn't smoke. The risk of lung disease, I think people do know about that the risk of emphysema is much higher if you smoke than if you don't. In fact, there's very few illnesses that cause emphysema apart from smoke exposure. And that can be both secondary smoke, secondhand smoke, but it's primarily from people who are smoking. And again, it's just astronomically higher in people who smoke compared to those that don't. And then there's cancer. You know about lung cancer, where again, essentially, if you talk to a pathologist, someone who dissects and does autopsies, they'll tell you that lung cancer is extremely rare in people who don't smoke or are not exposed to it. There are a few cancers, but not many that cause the lung cancer that are not related to smoking. But most of them are. But there's lots of other cancers that we now know are related to smoking. Things like bladder cancer, colon cancer occur several-fold more often in people who smoke than those who don't. The risk of infection is another issue. So we know that children, adults who either are exposed to secondhand smoke or who smoke themselves have infection rates 2 to 3-fold more than other people. So I'm talking meningitis, blood infections, pneumonia. Virtually all infections occur at a higher rate. The other thing that's interesting is the risk of mental health disorders, and it kind of goes both ways. We know that people who have any kind of depression or other kind of mental health problems probably smoke at a higher rate, and they do that because they're basically self-treating. We know that nicotine gives you a quick jolt of a chemical called dopamine in your brain. It hits you within about 5 seconds from when you take that drag. And we know it makes you feel better. And so people who feel bad are drawn to cigarettes because it makes them feel a little better for a very short period. We'll talk more about that. And in fact, the statistic that I learned this week that I didn't realize is that about 40% of all the cigarettes that are smoked in the United States are smoked by people with depression or some other mental health disorder. So the messages that tobacco companies give over and over again about, feel good, have a drag, those kind of messages ring true with people who have problems. So it's a very reinforcing thing. On the other hand, we also know that smoking can cause mental health problems and can induce depression. So you can take people who are perfectly healthy as far as their mental health goes, and if they smoke for long enough, they begin to develop depression and other signs of mental illness. And the reason that happens is that every time you take a drag, that little chemical I was talking about called dopamine gets depleted from your brain. And if it does it long enough, over a long enough time, it literally changes the structure of the brain and the way the brain works, and it can cause or induce depression and other problems in people. So we're learning a lot more about the brain and tobacco. There's more research expected. We hope to learn more about it. But some of the drugs that have been used successfully to help people quit, like Wellbutrin and Chantix, address that specific issue of dopamine production. They stabilize things, give you a more even brain function, and allow you to get off of tobacco by addressing that. So more in the future, hopefully, with that. So we're talking about HIV. So if all that stuff happens with tobacco in people who don't have HIV, what does it do in people that have HIV? Well, it does everything that it does to the general population. So if you have HIV and you smoke, all that stuff I just talked about is going to happen to you. But what we now know is that, in fact, it happens even more. So we know that the risk of heart disease, the risk of lung disease, the risk of cancer, the risk of infection, all those things are more. And let me talk about that specifically. I know we have some veterans in here. It turns out that in the study that was done in the VA hospital a few years back, they looked at the rate of emphysema in HIV patients. And they looked at those who were smokers and those that weren't smokers. And what they found was that emphysema occurred even more in patients with HIV who smoked compared to those who didn't. And it happened when they looked at it in HIV patients versus non-HIV patients, the rate of emphysema was higher in those who have HIV. So if you had HIV plus smoking versus just smoking alone, the rate of emphysema is higher, suggesting that something about HIV makes the emphysema worse, okay? And we think we understand that because we know that a lot of the products in tobacco smoke actually cause inflammation. And inflammation accelerates emphysema. If you have emphysema is basically destruction of lung tissue. If you have enough inflammation over time, it destroys the natural tissues in your body and causes fibrosis or scarring. And that's what's going on in the theory about why we think we see more emphysema in patients who smoke who have HIV. The risk of infections is higher as well. The SMART study, which was done during the period when we had antiretroviral therapy, showed that patients who had HIV, if we looked at just HIV patients and looked at smokers versus non-smokers, again, the rates were much, much higher in that study. And the same thing was done in New York City at NYU University, and they looked at PCP. When the SMART study was looking at all types of bacterial pneumonia, they looked specifically at PCP, and again, if they looked at HIV patients, they looked at smokers versus non-smokers, there was a threefold higher rate of PCP in those people that smoke. So again, it looks like there's something about how HIV accelerates the consequences of smoking. We have looked at cardiovascular disease and found the same kind of thing, and it's kind of funny, the numbers all look about the same, that there's about a threefold higher rate among people who have HIV if they smoke versus if they don't. And it applies for the things I've just talked about, but also about heart disease. So the risk of heart attacks and that kind of thing may be higher. Now there's some things going on there that you would worry about, but we're looking at all patients who in this group who had already started on protease inhibitor therapy. Y'all probably know, a lot of you, that some of the new therapies that we use can contribute to earlier onset of heart disease. And now what we know is that tobacco accelerates that even further. Again, we talked about mental health disorders. Again, increased rates of depression among people with HIV if they smoke. And again, the risk of cancer is higher. I'm going to show you some data from Arkansas in a minute that may give some insights into that. But when they look just at lung cancer, the rates for people who smoke versus those that don't, we expected them to be higher anyway, but they're even higher within the HIV populations than we expect if you smoke. And the other thing is other types of cancer. We talked earlier about colon and bladder cancer, but we know that in fact other types of things like oral cancers, which might be caused by not just smoking, but other types of tobacco people use. So if you chew tobacco or spit tobacco, the rates are even higher there if you have HIV disease. And the other thing about cancer, genital cancer, so we know that HPV, human papillomavirus, there's a new vaccine out that younger people are getting to try to prevent this. It causes cervical cancer in women, but it also causes penile cancer, cancers of the penis in men. And we know that for whatever reason, and we know that people, particularly groups like men who have sex with men, have high rates of this, but it looks like people who smoke within that group have even higher rates of penile cancer. And one of the reasons is that the strains of this virus that are more frequently cause cancer actually are more common in people who smoke with HIV. So the bottom line is there are a lot of bad things about smoking that cause worse disease in people who have HIV who smoke than we would expect. This is a slide that's a little hard to see, and I'll just kind of talk you through it. But basically, those people who have cancer in Arkansas, who have HIV and AIDS, have a very different distribution of cancers than the general population. Okay? If you look at the pie graph, and it's hard to see, but I'll tell you that the rates of prostate cancer, lung cancer, breast cancer, and colon cancer are roughly about equal. But in the HIV population, which is illustrated by the numbers up here, these bars that you see, the length of that bar equals the percent of all cancers that are found in HIV patients in Arkansas. And this is data collected from about a decade that ended in 2008. And you can see at the very top, the most common one of those is what's called non-Hodgkin's lymphoma. This is a cancer of the lymph nodes that we see in much higher rates in patients who have HIV. The second one is lung cancer. It's about 12% of all the cancers in HIV patients. And then you get to things that are unique to HIV, like cancer of the anus, or cancer, Kaposi's sarcoma, which is associated with a virus that's frequently found in patients with HIV. So the distribution is all different. But what I want to get to today is some data that I was playing around with this week. I wanted to look at some of the things that are specifically related to tobacco. Now, if you look at uninfected people in Arkansas and look at the rates of lung cancer, I want to talk about this number right up here. The number is 82. Now, that's the number of cases of lung cancer you would expect in Arkansas for 100,000 people. You would expect about that number of cases. But what we find for lung cancer over in patients in our HIV cancer group of the cases we have is that it's somewhere greater than 250 cases per 100,000, so a much, much higher rate, 3 or 4-fold. And the estimates I've made are very much conservative estimates. And if you look at colorectal cancer in the normal population, it's about 48 versus in our HIV population where it's over 80. And again, non-Hodgkin's lymphoma, where the typical rate is about 18, in our HIV cancer population, it's over 500. So there's dramatic differences. And one of the things we know is that there's very high rates of tobacco in our HIV population in Arkansas. And part of those high numbers is related, obviously, to the fact that these people who died or had these cancers had HIV disease. And we know that if your HIV is not controlled, your immune system is not working well to control these cancers. If medicine is taken and your immune system is working well, the rates are very low. So what we really don't know, and we're going to tease out in the future, is how much of this effect we think could be attributed just to tobacco use alone. But my suspicion is that it's very high. Now I want to shift for a minute from the 2 points that I've made, which is number one, we have high rates of smoking in HIV populations in our state and nationally. Number two, that the consequences are significant in terms of disease and cancer. And talk a little bit about the risk factors that people have for HIV and smoking. And they're a little bit different and there's some overlap. So we know that among the risk factors for HIV is IV drug abuse. And the numbers there are very, very high for tobacco use, in some estimates as high as 92%. That unprotected sex is another high risk factor, particularly among men who have sex with men. And the rate of tobacco use, again, is very high there. We don't have Arkansas-specific data. We know that African Americans are unduly represented among the HIV population, much, much higher than we would expect. What about smoking? What are the risk factors for smoking? Well, they're kind of different. The things that we talk about when we say what makes you start smoking, well, it's usually your peers smoke, your family smokes. Well, it turns out for HIV, people who are living with HIV, a lot of their peers smoke too. So there's some commonality there too. We know that poverty is a big factor. Low SES stands for low socioeconomic status. Basically means people who are poor. Those people smoke at higher rates than people who are better off. And again, it's a little bit higher in the Caucasian populations, although unfortunately that disparity is going away. We're starting to see much more emphasis on the tobacco companies marketing to African American populations even more intensely than they ever have before. They used to push Kool and other brands of cigarettes that were specifically marketed to the African American population. Now they're really putting on more pressure, and again, things like an executive branch and other tobacco products are being really pushed hard to the young, upwardly mobile African American population, as well as poor black people. Depression, mental illness, again, much more common among smokers and also something that we see in the HIV population. I want to talk a little bit about what people believe who have HIV and what they think about smoking. And these are from various surveys that have been done. They believe that nicotine helps with depression and anxiety. Well, yeah, it does in the short run, but not in the long run. Yes, if you smoke and take a drag right now, you'll feel better in a minute or two. But over the long haul, it'll actually create more anxiety and depression as you go between cigarettes. The other belief is that a lot of people believe actually that smoking actually increases your CD4 count. They believe that it helps you fight infection. And we don't know where that came from. There's just nothing to support that. There's no scientific evidence to support that. And I'll show you some other stuff that will make you wonder where that came from in a minute. The other thing is people with HIV, particularly those on protease inhibitors, are worried about their physical appearance because they start to put on weight and their body shape changes. So they think maybe if they smoke, they can control their weight. And in fact, there may be some truth to that. And when people quit smoking, which is what they worry about, that I'll put on a whole lot more weight, we do see more weight in people who are on HIV medicines than those people who are not in terms of the amount of weight they gain. So that's a reality we have to accept and acknowledge, and we have to help people argue, well, yeah, you're going to gain a few pounds, but think of all the other things that you're going to gain. Okay. Now, here's a striking reality. This is a new paper that was published a couple of years ago. It's about TSE, which is tobacco smoke extract. So what happened is these scientists went into their laboratories and they were growing up HIV in cell cultures, okay? And this is something they do on a regular basis to study HIV. And they took cell cultures and they just looked at the rate of HIV growth. And it was growing at about this rate, okay? And then they put in some natural substances that would reduce the rate of growth of HIV in the laboratory situation. And it did what they thought it would. It reduced the amount of HIV production. And then they went back into the same vial. They added tobacco smoke extract and looked at the rate of HIV production, and it dramatically went back up, even higher than the baseline. And they said, well, this is really interesting. And so they looked at some of the genes that they knew helped control HIV growth. And what they found was that the tobacco and nicotine product actually turned off the systems that tried to control HIV, and it actually turned on the genes and the systems that promoted the growth of HIV. Okay? So we need more work in this area. This is very tempting and interesting research, and it needs to be duplicated, and we need to see further work. But it looks like there are actually factors in tobacco that actually cause HIV to spread within your body. Okay? So, no, it doesn't increase your CD4 count. In fact, it may actually increase the rate of HIV growth and explain a lot of the problems that we see. What are the other impacts of tobacco on HIV disease? Well, there's all sorts of other things that we've noted. You know how you get HIV disease, and one of the things we forget about is that mothers can give babies HIV disease. We know that mothers who smoke are a big at-risk group for not taking their medicine during the last parts of their pregnancy. If they take their medicine during the last parts of their pregnancy, the chances of delivering a child who is HIV-free are greater than 99%. Okay? But we know that if we have a mom who comes in as a smoker, that's a big red flag. We need to really work with her extra hard to make sure that she takes her medicine, because a lot of those moms stop taking their medicines, their viral load goes up, and they deliver a baby who winds up being infected. There's other things. We know that people with HIV develop kidney disease as a result of their HIV, and we know that tobacco makes that worse. We know that tobacco increases the number of genital warts that people who are living with HIV have. So the list kind of goes on and on and on. Now, let's talk about cessation. Let's talk about helping people living with HIV who smoke, helping them to quit. And let me say, there's 4 approaches. One is to do nothing. Some people will quit on their own, okay? Very small number, probably 3 to 5% over a year will quit on their own. There's people who are willing to quit who can use different drugs. You've heard of nicotine replacement therapy, the patches, the chewing gum. And then there's other drugs like Chantix and Wellbutrin that are used to help people quit as well. And then there's counseling. There are some people who just go into counseling and they work very hard over the quit line or whatever to quit, and they're able to quit as well. And then there are some programs that use both drugs and counseling. And the problem is we don't know a lot yet, because this area, the group of people who are living with HIV, has not been studied very well by people who do this research. But I'll show you a few things that we know. Some of the studies that have been done show that there's really no impact of certain things that are done to help people quit. This is one of the largest studies ever, enrolled almost 500 people, and they took one group of people and they gave them just nicotine replacement therapy. In another people, they did what's called motivational interviewing, where psychologists sit down or counselors sit down with people and help them sit down and weigh the pros and cons and kind of get them to come to their own decision to quit. And it turned out they both rates were a little bit higher than doing nothing, but they really weren't what we wanted. They only got about 10% of people to quit in either group. But the thing we know about cessation is it really varies from, technique to technique, from person to person. There was another study which used a stronger drug that's been shown to be better for people who want to quit, called Chantix or varenicline. And they did a 12-week program where they did telephone counseling, and they used either patches or they used Chantix. And what they showed was that at the end of 3 months, about a quarter of the people who tried the Chantix actually had been successfully able to quit. This is not too far off than the numbers we see in the general population, okay? So one of the big things is, well, people with HIV have so many things going on, they can't quit. Well, that's wrong. They can quit. And this is one of the studies that showed that they were very successful. Now, you do worry, people have heard that Chantix may cause suicide, okay? It's because there were a few people who were on it who did commit suicide. And it is a risk that you have to explore before you start this medication, but the risk is extremely low. And out of the 400 or 500 or the 200 people that were in the Chantix group, there was one person who started to get a little worried and started to feel like, maybe they were thinking about suicide. That person was quickly identified, taken off the medicine, and did fine. So, it's just one of those things you have to know is a risk, the provider has to know. But the good news is, all the rest of the people did very well, didn't have any side effects other than a little stomach problems, little mood disturbances, but they were ultimately, once they got off the Chantix and quit, were able to live a healthy life. Another study showed that just counseling alone worked, and this was a group of patients from New York City and the Bronx, largely African American, largely heterosexual, largely unemployed, and they had psychologists and peer counselors compared to nothing, and they were able to quit again at about double the rate. So about 20% of them were able to quit. So bottom line is, you can succeed at getting people who smoke, who have HIV. They can quit. Now, what do we know about barriers to success? We know a few things. Number one, first problem is that we doctors are not doing a very good job of even trying to help people quit, okay? It is rare for any of us who, in the audience, who may have HIV, to go to their doctor's office, and for their doctor to actually ask them about tobacco and actually try to help them quit. Probably only about 20% or 30% of the time does that occur. We as a profession have to do a better job there. And it's not just people with HIV. We do a terrible job for everybody else as well. But that's one of the problems. The next thing is, in our public health programs, we need to get to people with HIV who are smokers. And we're not going to the right places. So we're not going where the very high rates are. We're not going to the places where IV drug users hang out. We're not going to the bars where men who have sex with men go. We need to get in there with these anti-tobacco messages. The other barrier is that there are some drugs that cause problems with HIV drugs. So again, Wellbutrin or bupropion has a lot of interactions with ritonavir and other related drugs that are used to take HIV. So that's probably a drug that we shouldn't use. We should look for other things. So sometimes there's limits to what we can use to help people quit. The other thing we have to recognize is that a lot of people who smoke have other addictions. There are very high rates of smoking among people who have HIV and use alcohol or have an addiction to alcohol. Same thing with drugs. And if you look in, the number of people who are smoking with HIV, probably 40% of them are regular overusers of alcohol. About that same number use marijuana. 20% use opiates, and you can read the numbers off the screen there. 10% cocaine, about 9% amphetamine. So there's a lot of co-addictions. If we do not address this, we will not have success in helping people quit. So we have to come to terms with their addictions first. Depression is another barrier, and it's the same thing there. Until we help people address their depression, they're not going to have the ability to quit smoking cigarettes. And finally, another big barrier is that a lot of people are very poor and they can't get access to the drugs they need because of cost. They can't get into counseling because of cost, and we need to figure out ways to address that as well. Now, what are the benefits for people who have HIV who quit? Number one, It's been documented. Again, the research is just starting. But among those who quit, they absolutely see improvement, not just in the smoking-related symptoms, but their HIV-related symptoms. And this has been documented to occur relatively quickly upon quitting smoking. The second thing is they have reduced heart disease. And again, just like the general population, there's a relatively quick benefit that occurs within a year or two in the rates of having heart attacks or other kind of heart problems. Reduced pneumonias and infection. Again, the benefit is very quick. You start to see reductions in infections within a year or two. So to summarize this lecture, and I'm sorry that it's been such a lecture for you, but these are facts that everybody in this audience really needs to know. The summary is that there are a lot of people with HIV who smoke, and that we've not paid much attention to it. Number two, that for those of us who are taking care of either our friends with HIV or we're doctors and we're taking care of patients who have HIV, there are a lot of extra diseases and problems that people have because they smoke. So we need to get on the ball, all of us, to make sure that we encourage our friends and our patients to try to quit. There are many barriers, and we have to acknowledge what they are and recognize them and try to deal with them. But if we deal with it, then we can help people quit very effectively who have HIV disease. And that we need to convince them that there are benefits that will occur if they quit. So, this is my thoughts about HIV and tobacco. If you have questions, I need you to write them down on some cards that are on your table. And if you'll pass them up here, we'll start to collect them, or Mark will walk around and collect them. We can start to address some of your questions. We've got about 10 minutes or so where we can try to answer these things. Thanks, Bob. I appreciate you gathering them. So, I have a lot of questions from this table. One of the questions is, if you're diagnosed with emphysema, is it highly dangerous? So the diagnosis of emphysema means you have reached a point where there's been enough damage to your lung that it's hard for you to get oxygen into your body. So the answer is, yes, it's dangerous. And if you quit smoking, it will stop that progression so that the emphysema gets worse. So it means that your physician or provider has recognized that you're at a critical point and you're going to have more problems breathing if you don't quit. So yes, it is dangerous. And it's important to know about that early. So again, regular care by a physician is important. Number two, what are your chances of living a long and healthy life if you quit? Well, the chances are really good because most people will begin to see benefits from quitting smoking literally within hours after they stop. Their heart rate will begin to go down. Their blood pressure will begin to go down. The benefits in terms of heart disease will get back to the level of the normal population often within about 5 to 10 years, but some of those benefits occur really early. The risk of cancer continues to be present, but it decreases every year that you've quit. And so you can live a long and healthy life if you're able to stop. Another question about emphysema, how is it treated? Well, the treatment depends, and it's very specific to the individual. Some patients sometimes require surgery because a part of their lung is so damaged that it's just better to take it out. But generally, there's not a lot of treatment that we have to offer for emphysema other than oxygen therapy and sometimes other types of therapy to open up the lungs to help you breathe early. There's a question here about where can I find the data in the presentation? Mark, do you want to, are we going to be able to post this? Okay. All right. So for those who have attended today, Mark will accept the responsibility of sending you copies of my slideshow. And on it are the references with the articles. And if you go onto the internet and copy that little reference and put it in, you can most of the time pull that article up. There are some articles that you'll have to go to the library and get somebody to pull for you, because otherwise you have to pay money to get a copy of them. But certainly the slides, whatever data's on the slides, is available to you. Let's see. What about thyroid cancer and its effect on smoking? I do not know, and maybe Nate or somebody else in the audience knows, whether there's a direct effect of smoking on the incidence of thyroid cancer. Most thyroid cancers are not related to smoking, and I'm just going to have to say I'm sorry I don't know the answer to that specific question. But I will say, the longer we go and the more we study different types of cancers, it seems like almost every cancer is somehow related in some way to smoking, and that it occurs at a higher incidence, but I don't know about thyroid disease itself. Here's a question. There are many cases of HIV being cured. Why are they not talked about as a solution of how, or about how they were cured? So that wasn't the focus of my talk. I'd love to talk about that. At this point, the truth is we've never, the only cases of HIV that have been cured are a very, very small number, literally a handful of patients who had bone marrow transplants in very unusual situations to cure their cancer. There are a very small number of people, more than a handful, in the world who are born with a genetic feature that protects them against HIV. And it's been possible to take people who have that abnormality and do a bone marrow transplant, but it's a it's an experimental process. It's not really something that's practical. What is true is that we have very effective therapy. If you are diagnosed with HIV today in 2012, you can go on one pill a day and your HIV load can go to 0, and you can live a completely healthy and normal life with very minimal side effects. So we are in an extraordinary place. 21 years after my friend died, and we were hoping and hoping at the time he got his illness that there would be a breakthrough, and it unfortunately didn't happen until after he died, but there's been breakthrough after breakthrough so that we are now successfully able to treat people. That's why it is so critical that we find people who are living outside of the care system, who have HIV, who maybe know it or maybe don't know it. We've got to find them, make sure those that are not diagnosed get diagnosed, and that those who are not in care get into care so they can live a productive life. Do you have the number of HIV and Latinos? I don't have that number at my fingertips. We are beginning to see a rise in HIV disease in Latino populations, particularly on the East and West Coast. As people move into the United States from Latin America and become acculturated, a lot of people among Latino populations are adapting American culture, and they are becoming, they're doing all the things that other people do to acquire HIV, using IV drugs, having unprotected sex, and those groups are beginning to rise. I do not have numbers at my fingertips, and maybe one of the other speakers can try to address that a little bit later, but the numbers are beginning to climb. I think that's most of the questions, and we're just about out of time for my segment. I want to thank you all for listening, and I hope that among all the things and the other different issues that you address around taking care of your friends, your colleagues, your patients with HIV, that you will begin to consider the role of tobacco as a very, very important problem to address, and that if we all work really hard on this, I think we can be very successful in improving the lot of people who are living with HIV. Thank you very much.
Thank you, Dr. Wheeler. And If there are additional questions that you have of Dr. Wheeler, if you would write them down and just get them to me through the day, I will try to make sure that we facilitate an answer and try to get it back to everybody. So we'll kind of make that an ongoing process. But if you have a question that you would like directed to a previous speaker, just make sure that you identify the speaker so that we route it to the right person. And I would also like to take this opportunity, Dr. Wheeler, if I can get you to come back up just for a second. We'd like to give you a certificate of appreciation for speaking this morning, and thank you very much.
Thank you, Mike.
For everybody who has had the opportunity to speak in front of people, crib notes are kind of an important thing.